Hello, everybody. My name is Dr. Erika Phelps Nishiguchi. I'm a developmental behavioral pediatrician, and that is a subspecialty within pediatrics where I am trained as a general pediatrician, and then I went through further additional training to become a developmental behavioral pediatrician. So this is a medical doctor. So I'm a medical doctor who specializes in the health and behavior and development of children and children with developmental disabilities like um, developmental delays, language delays, autism spectrum disorders, cognitive or intellectual disorders and disabilities, learning disabilities, other neurodivergence such as ADHD, attention deficit and hyperactivity disorder. So these are the conditions in which I specialize. And many of these conditions come along with sensory differences because these conditions are neurological differences. And so I was asked a few years ago to provide a medical perspective on the sensory differences that people with neurodivergence experience and to help guide families in how to experience sensory success. I usually give this presentation along with Susan Wood. However, we were not able to come together to do the post-spin conference recording together, so hers will be available separately. Um, okay, I think I'll just move forward to the next part here. Uh-oh, maybe. Here we go. Okay, so today we're going to talk about, another piece of my introduction that I should say is that I was previously working with Hawaii Pacific Health and Kapiolani Medical Center in the Developmental Behavioral Pediatrics Clinic, and I was at the time of the SPIN conference in May 2025. However, I have since left the employment and Hawaii in general. So I'm giving this presentation from the mainland. And so unfortunately, I am no longer practicing clinically in Hawaii to be able to provide direct clinical support to children with neurodivergence, but I still hope to be um, uh, contributing to the care and well-being of children with disabilities through involvement with SPIN, Department of Health activities, and other activities, although I'm now on the mainland for the time being. Okay, so the table of contents for today's talk is an introduction to the senses in general, since we're talking about sensory experiences. And then we'll talk a little bit about the theory of sensory processing, and then how sensory experiences impact behavior. And then finally, we'll talk to some of the specific supports that you may be able to give to support the individuals in your life who have sensory needs. So let's think about the nervous system. So when we think about senses, most people think about five senses that we've learned about. I first remember learning about them in kindergarten. So many people have experienced learning about the five senses throughout their life. And those are our visual senses or our sight, our hearing, audio perspective, audio processing, smell with our nose, um, uh, the hand is for touch or tactile sense. We can feel this more than with just our hands, right? We feel touch in our feet and other parts of our body, like really anywhere on our body, we can feel touch. And then taste with our tongue. Um, so our sense, our our sensory organs pick up the sensory information through nerves, and we have nerves that both receive and process sensory experiences, as well as nerves that transmit information, such as our motor responses. And so nerves really drive how our body uh, understands, recognizes, and responds to our environment. And nerves both will so sensory nerves in our sensory organs like our eyes, our ears, our nose will take up that information and send it back through the nerves to the spinal cord, and then our spinal cord then goes up and directly communicates with our brain, and our brain is responsible for then integrating all of that sensory information through our emotional processing, through our more higher level cognitive processing to understand, like, is this a threat? Is this like what what information am I supposed to take from this sensory experience and then determine how our body should respond to that. And so our brain really is responsible for taking and processing all that information and then sending our body's response back out through the spinal cord into the nerves to show how we react. And so all of this is neurological. And as you can see, our nervous system is really throughout our body and it's not just in our brain. But it turns out that there's more than just those five senses. You may have been hearing more about some of these other terms, proprioception, interoception, and vestibular. So these are three other senses that most people don't think about when they think about their senses. And even most medical doctors aren't going to think about those. Although I will say that I learned about each of these in medical school. It wasn't until I was in fellowship and even practicing as a developmental pediatrician that I really understood how these senses are just as impactful as our five primary senses. And I'm going to pause here for another introduction statement that I failed to mention at the beginning, which is that in turning this presentation into the spin's magical theme, I used Canva and used artificial intelligence to generate some images. And so unless my images have a um, an image citation on them, I've used artificial intelligence to generate these fantastical um, images here. So what are these big words? So proprioception is the sense like that our joints and muscles send back through our nerve endings to the spinal cord, then to our brain to show where our body is in space. And so they are able to help our brain understand exactly where our arm is when we're reaching out, or where our arm is once we've kind of cocked our shoulder, bent our elbow. It is the processing of how our joints and how our muscles and bones are aligned that allows our brain to then go back and understand where that body part is. So if you imagine closing your eyes and putting your arm out in front of you or taking a step forward, it is your proprioceptive sense that allows your brain to know exactly where you are in space. And very often, our proprioceptive sense will communicate and be processed with other senses, such as, the touch, tangible sense, visual sense, which is why sometimes it's so much harder to understand where we are in space if we take out the visual input. And then interoceptive sense or interoception is the senses on are the nerve endings picking up sensory information from our internal organs to feed back sensory content. And so that, for example, an interoceptive sense is the feeling of like hunger or feeling fatigue or feeling like anxious. Like it is those uh sense inputs from our internal organs like our stomach, our GI system that's sending back to our brain to say, look, we need more food in here. And then the vestibular sense is the sense of balance that comes from our inner ear. And so when we spin around and get ourselves dizzy, for example, that's our vestibular sense saying like, whoa, I'm a little bit out of whack right now, sending back that process, I'm a bit off balance. Vestibular and proprioceptive senses, you can imagine, work together a lot. Vestibular sense can be impacted by things like vertigo, when you're feeling like you're dizzy or you're spinning, even if you're actually in standing in one place or sitting in one place. Another sense that I've not mentioned specifically is the pain sense, but we actually have many different types of pain receptors, and we have like um, uh, pain for like the kind of physical pain of pressure or like very light touch. And then we have pain from like hot and cold. And those are also processed through our nerves, which is part of our nervous system. You may have heard the terms sensory seeking and sensory avoiding. These are two ways of thinking about or conceptualizing how our bodies respond to all the sensory information. And this is where we cross over from what we consider like core medical knowledge that has clear biological underpinnings, which we have for the all the nerve-based sensory information. We can show that on if we did anatomy work or we look through microscopes at how our nerves look and how and kind of understand how they process, we have medical knowledge to show how the senses integrate with the rest of our body. For the idea of how we register and understand and process that sensory information, this has less biological underpinnings at this point. It's not something, for example, that I learned about in medical school, but and medicine really hasn't um, studied these concepts as well. And so I'm moving here from medical discussion to discussion from some of our allied health professions who have really studied this further. We started to understand sensory differences and like that different people can process the same input in different ways through people sharing their experience of something that one person might say, "Oh, I don't this doesn't bother me," and someone else says, "Well, this really does bother me." We started seeing that not everybody seems to perceive the senses in the same way. And so their brains are not reacting to the same input in the same way necessarily. And the health profession that has really explored this in more depth is occupational therapy. And so looking at the occupational therapy literature, they have shown these different models of sensory processing. And this is one model of showing in a kind of two axes form to create four quadrants that we have four different ways that our brains can process and respond to that neurological sensory input. So on the x-axis, which is that horizontal axis that goes across. Actually, let me start with the y-axis, which is the axis that goes up and down. Y-axis is how much our sensory receptors out in our sensory organs are sending back information. So somebody who is really on the lower part, I don't know, can you see my arrow?
Yes.
Okay, so here on the lower part of the y-axis, we have hypersensitive. So that means that um, our sensory nerves need very low input to send back a signal to the brain to say, "Oh, I'm feeling something here." And then up on the far end of that spectrum, we have hyposensitivity, which means we need a high threshold, which means we need a lot of input into that sensory organ for the nerve to send back that information to the brain to say, "Look, we're getting something here." And then on the x-axis, which is this horizontal axis here, we have what does our brain and body do to respond to that? And so um, starting over here on passive regulation, it's like our brain just says, "Okay, thanks for that information, cool." And we don't really need to do anything about it. It's like this is just a part of being, and I'm getting this information, but that's okay. And then on the other end of that spectrum, we have active regulation. And that is when our brain says, "Ooh, there is something about this sense that is bothering me or is dangerous to me, or that I need to do something about it to regulate myself. And so I'm going to do something with my body to help get whatever it is that I need." So for somebody who has, and when I say somebody, I need to be clear here that people can have different reactions to different senses. It's not like you react to all sensory stimulation in the same way. Some people may only have like one sense that they react very clearly, very strongly to, but and some people will have like multiple needs within. So um, I hope I'm not confuddling this too much, but um, when we're thinking about one specific sensory input that comes in, our brain can respond to it in these different ways. So, an example would be um, somebody who is sensory seeking. Very often we see this in kids who like seem to want to spin on these things that would make me dizzy in a moment. They want to spin on them indefinitely. This is somebody who is really enjoying that vestibular sensory input that they're getting, and it helps them feel good. Or maybe it helps them regulate other experiences that they're feeling. And so somebody who is sensory seeking would need a lot for this for the vestibular input would need a lot of spinning to get a satisfying feel, and in order to regulate themselves they like go out and they actually try their best to get as much spinning done as possible. um, Whereas other people like me, I'm going to try to I'm very sensitive to that vestibular input, and at the first sign of like some kind of odd motion, just honestly, even just talking about it right now is making me a little bit dizzy. So my brain is saying, wow, I need to do something to get myself away from this feeling so that I can like feel better because I'm starting to feel nauseous and we don't want that when I'm in a presentation. So then I have like a sensory avoiding um, feel to vestibular input. And another example is like nails on a scratch board, or I mean on a blackboard, or like cat's nails on like a glass window pane. Like you get that really shrill feeling sound, right? And most people will like in process it as like, whoo, that's like a very uncomfortable sound. I need that person to stop making that sound immediately, or I need to get myself away because it just feels so uncomfortable. Whereas other people are like, dang, like I want to listen to super loud, shrill, I don't know, heavy metal music, for example, right? It's like I'm going to go out of my way to get that input. And so we can have different experiences, and hopefully some of these ideas have shown you that even people without neurodivergence, people without a neurodevelopmental disorder or disability can have these same types of experiences. But what we know is that, or what we have learned is that people with neurodivergence, as they have brain differences that are leading to their autism or intellectual disability or speech or learning impairment, something is different about how their brains are built. And as the sensory experience, nervous system is an extension of our brain, it's very biologically plausible um, and likely that there's something different about how their senses are communicating to the brain, which then leads to more sensory needs in one way or another. I hope this was somewhat clear. Um, So sensory differences, I just went a little bit in depth with a couple different examples, but here coming from a medical perspective, thinking about like how do sensory differences show up in the clinic setting? So in my office or in the general pediatrician's office or in the emergency room or in a hospitalization, there's all sorts of different ways that a child can be responding to the different sensory experiences in this space. So vision. So in clinical settings, we tend to have very bright fluorescent lights. There's tends to be a lot of action, especially if we're in the emergency room or the hospital. And so like our brains are constantly receiving a high level of input. And so children with sensory aversions or hypersensitivity to vision might be very overstimulated by that input. Um, there's a lot of different sounds. So thinking about hearing, there's unfamiliar sounds. We may be hearing other children who are feeling distressed, like the child in the next room who's crying because they're getting their vaccines, or um, um, hearing team members talking loudly to each other outside the office door, that can be very distressing to children for different reasons. Oftentimes in the medical setting, there's different smells. There may be very unfamiliar smells. There can be a lot of strong smells. Even just like the cleaning equipment can leave a room smelling very strongly of that like chemical smell. And some people are very sensitive to those different chemicals. Um, Communication, children who have communication challenges may have heightened challenges in the medical setting because they don't have their familiar communication partners, or people aren't interacting with them in the same way that they do at school or in therapy. They may not have access to their augmentative communication if they use an AAC device, for example. There may be a lot of requirement for eye contact, or there may be like this kind of hurried pressure or this stress, especially like in the emergency setting, where there's this like additional pressure that's coming along with communication that is feeding back and kind of contributing to this overall sensory experience that a child has. Um, Touch, we really violate touch a lot for children in medical settings. We require vital signs and, in most offices, vital signs are done first. And so that can be a very unpleasant experience for children. Like, I mean, when I get my blood pressure done, it makes my arm fall asleep and I know what's happening and I don't like that. Um, for children, this like idea of it being an arm hug, which is usually a nice, warm, cuddly thing, is like this is actually like restricting and sometimes feeling very painful. And so it can be very off-putting for children. Um, our physical exams is, getting into physical space. Sometimes in the ED or in the hospital or in the clinic, we're doing some kind of intervention that causes pain or fear for a child. And many kids with neurological differences and disabilities may have increased pain sensitivity, like we discussed earlier, or they may have that, different um, touch sensation to touch. And so all of this can lead to anxieties. We'll talk about that a little bit more on the next slide, but further things that can add to the anxiety of a medical environment is like being out of routine in general. It's very hard for many children with developmental differences. We may have remembered us that scary things happened here before, and so we're on heightened alert coming into this space already. And we actually know now that many of our sensory experiences are very strongly coded with emotional responses. And so, and our emotional centers of our brain are deeper than our rational centers of our brain, which is in our cerebral cortex. And so our body and our brain responds more quickly to emotional memories, very often, even before we may have a reaction or a response with our body before our rational brain has even had a chance to process that information. And so kids may be acting out in a medical setting just based on emotional reactions. There's unfamiliar people that can be really scary for a lot of kids. And then for many of our kids with developmental differences, with language differences, with autism, they may have reduced understanding and can't really express themselves well. And anytime we're in an unfamiliar place and we don't understand what's going on, we feel apprehensive, and that heightens our um, emotional response. So that's just an example of the medical setting. But everyday life has lots of sensory experiences as well. So thinking about like kids in school, right? Again, here's my artificial intelligence getting so creative here. So here's a wizard and a wizarding academy, but our children going to school, there's again like lots of different sights and sounds and feelings of distress and feeling of pressure. Um, in our daily routines, like our hygiene activities, like, brushing teeth is a very highly sensitive experience for people. We have a lot of nerve endings, of sensory nerve endings in our mouth, and that's tactile and smell and taste all together, right? And so that is very often a really challenging activity for people with sensory differences. But even washing hands or bathing, washing face, getting their face or hair wet can be really hard for many people. Um, I wonder if you can think about like going to the grocery store, or the farmer's market, or somewhere like there's lots of different sensory inputs in those settings too. Like thinking about the smells of the different foods. I have a hard time walking by like um, my nose is very sensitive to the fishy smell, right? And so some kids may be very perceptive of um, different smells in different aisles. There's air conditioning. There's lots of people, lots of different sensory input that can be coming. Plus, there's often, um, competing, like there's toys displayed in the cashier register, and that's other visual input that then stimulates other parts of our behavioral response. Um, This picture is depicting a haircut. A lot of kids have sensitivities around, getting their hair touched or cut or brushed. And then you have, the sounds of the buzzer or the scissors that can be really challenging. And then even what we would think of as maybe more fun activities, like going to the playground, going to a water park, going to the beach, like those all have very significant sensory inputs as well. And so if you think about it, like your child or your loved one with sensory differences is experiencing sensory input all the time. And things that we may just discount as normal everyday life because we're on that left side of the quadrants that I mentioned to you earlier may be um, popping up in ways that are unexpected and sometimes in ways that take a lot of digging to get to. Okay. So here I talk a little bit about the uh, how sensory input impacts behavior. And I alluded to this a few slides ago when I mentioned about the emotional processing center in our brain, which is the older and more quickly responsive part of our brain. And so when we have sensory input, the job of our brain is to take that sensory input and process it back through the spinal cord to the brain, and then let the brain decide what to do with it. And so first, the brain at first is received in our emotional centers, like our amygdala and our limbic system, where our brain senses like, okay, is this like something that I need to respond to right away? Is there an emotional response? Is there some kind of reflex response that I need to respond to right away? And then it will send out information. So, for example, if we touch a burning hot stove, we touch and flinch away immediately. We haven't thought about whether anything about that stove. It's just we touched it and we flinched. And then delayed, even if it's by a millisecond, our cognitive center, which is our cerebral cortex, our prefrontal cortex, which takes that further information and really like analyzes it and determines was it safe, was it not, um, can then override that initial reflex. But our body is going to respond based on that emotional or safety um, input before our brain has a chance before that information is sent back up for the brain to say, what else can we do with this? And so um, the key point here is that our emotional center and our safe, not safe part of our brain is processing this information before it gets to our higher level of thinking and processing. And that initial response can then trigger our stress activation. And stress activation is a part of our nervous system that is called the sympathetic nervous system, which is the fight or flight part of our nervous system. And that is when our body immediately releases stress hormones into the rest of our body to keep ourselves safe. So first is in causing this immediate reflex withdrawal from the hot fire. But then it's also like priming our body to jump and run away if, say, we had fallen into a campfire and we need to get out of it. Our body sends us lots of hormones to engage our body and say, get out of here as fast as you can. And all of that, all of those hormones then are leading to the behavior and what our body does. And very often the neurologic response to threat is that fight, that like we've got to fight whatever it is, or flight, which is we got to run away from it. And so we're getting increased heart rate, we're getting increased blood pressure, our muscles are really primed to do something. Um, there are other aspects of fight or flight response, which is like freeze or fawn, but really those are the much less common stress responses. Um, and so these sensory um, inputs that kids are getting, or anybody, it's not just kids, are can lead to a behavioral reaction very, very fast. And as soon as you overlay anything else, like a communication disorder or a processing disorder, you can see how we can um, spiral behaviorally um, very quickly if we don't have a chance for our um, rational part of our brain to understand and calm our body down. And in many cases, kids are reacting to things that their loved ones or teachers, parents, doctors aren't fully understanding the gravity or the depth of the sensory response that they're getting. And so we may be like, oh, it's okay. It's just like a small little, arm hug, right? Where maybe some kid is getting this very strong sense from their body that this is something I really have to get away from. And so if we can understand what our kids' triggers are, we can help to engage the opposite part of our sympathetic nervous system, which is the parasympathetic nervous system, or the rest and digest, and learn strategies for teaching our brain that this sensory activity is okay, we can get through it. So let's talk a little bit about recipes for supporting kids. So the first thing is understanding, and hopefully the rest of this presentation has helped you understand the theoretical and biological basis for sensory differences. And now we'll talk a little bit about what we can do to support kids through. So first and foremost is just being alert for sensory contributions to behavior and being um, like really thinking thoughtfully about anything that is causing a child distress and peeling back um, past the most obvious um, reasons to really dig under for something sensory or many different sensory things that may be coming together and causing this stress activation. A second recipe is to modify the environment. And this can include how we set up our home environment or create a calm corner at home or at school, but also thinking about, can we create a sensory kit on the go? So many families that I've worked with in my clinical practice have created some kind of sensory kit that they bring in their purse or their backpack, so that when they encounter something sensory, something that may um, reliably cause a sensory-based reaction, they have some way to support their child through it. So for example, when we think about sight, my office has the ability to dim the lights, and so many of my families will say, my child's really sensitive to the fluorescent lights, so can we dim the lights? And we can do that. Many places don't have the ability to dim lights, so you're walking into the grocery store or you're at the beach, you can wear sunglasses. Sunglasses indoors or outdoors is fine. And then sometimes we can react or respond to a aversive stimuli through regulating some other sensory need. Like, so if our body is getting like a lot of input that we don't like, sometimes it can be helpful to like hold a stuffy or like feel like deep touch, for example, just um, some other sense that we balance out in a different way to help um, provide feelings of safety to our brain, even though it's still receiving that of more aversive or perceived harmful stimuli. Um, we can use sound to help, like have many kids will wear headphones or earbuds that block out noise or muffle noise, or even that provide an additional stimuli, like a calming music or something that helps with processing. Um, in the medical setting or any other setting where there's lots of people talking and trying to interact with somebody, trying to use the concept of one voice, which is just having one person who's assigned, like letting all the adults or other children in the room know, like when we're communicating with this person, we just need one person to channel because it gets confusing if we have too much information coming from too many people. And that one voice can be, one of the medical team, or it can be the parent. Um, we can use touch, we can use like fidget toys. There's all sorts of different types of fidget toys now. And in the spin conference and other workshops where we do this sensory workshop, we provide some examples. But there's like the squishy toys of various different squishy textures. There's spinning toys. There's toys that pop, because like feeling that popping sensation can be really um, calming for some people. Um, we can use touch when we're trying to help kids with process and prepare for uncomfortable medical experiences. Like, so for example, when to prepare for getting a shot, either your vaccines or some other shot, like some kids need monthly shots for allergies, for example. You can get doctor play kits and practice with a stuffy and then practice on yourself to help help understand what's coming and help practice calming strategies. So calming strategies that can help when we're getting a shot or some kind of injection is to use like Buzzy the Bee, which is a an ice pack that vibrates, that confuses our sensory input so that we don't feel the pain as much. Um, or we can use numbing medications. Um, we can, um, sorry, I like totally blinked right then about my other example, but within medical play, you can do this yourselves, and then you can also look for ideas on YouTube. Um, Sorry, I need to pause. I need to. Okay. Okay, sorry about that. Even sensory wizards and witches need to take a little sensory breaks every once in a while if something comes up um, that is overwhelming. So anyway, coming back to modifying the environment. So um, smell is another way that we can help distract or provide sensory regulation for otherwise aversive experiences. So essential oils, aromatherapy, even using a mask if we're going to go into, a grocery store and a child has a heightened reaction to smell. You can have a mask with a little cotton ball in there with different essential oils with different smells, and sometimes that can be really helpful. So some families will have this bag, like a sensory kit created to help with everyday outings, like going to the grocery store or going to the park. Sometimes you'll create a special one for certain events, like one of my patients had to go to a wedding, which is, usually a very joyous experience. But for many kids with autism, it can be really overwhelming because there's so many people, there's loud music, there's lots going on. And so they took a little tent and put a lot of uh, made a little sensory calming corner where he could escape when he needed to, and practicing using the kit or these tools in advance of an upcoming known stressful event can be helpful, and getting into the habit of using it for everyday activities can be helpful. And so this is modifying the environment and being prepared when we for known or expected sensory differences. In the medical setting, I strongly recommend that if you are at Kapiolani Hospital for the emergency room or admitted, I strongly recommend that you ask your team to contact Child Life. Child Life are professionals, allied health professionals who specialize in medical play and sensory play and developmentally appropriate engagement with children to help reduce the negative experiences of being in the medical settings. And they do have special expertise of working with kids with developmental and sensory differences, and they can be very, very helpful members of the healthcare team. And then, of course, in the school setting, like asking for occupational therapy input, for behavior therapist input on how to create a modified environment or sensory breaks can be very helpful. Providing a safe space is helpful both at home, school, creating a portable space for like the tent can be helpful. And then offering sensory breaks, which allow for stimming and regulation. So this is very, very important. These sensory inputs, like we mentioned, are happening all the time. It's 24/7. Even without the aversive pieces or the uncomfortable pieces that come in. And so allowing if a child is is in a situation where they're getting prolonged exposure to something that is aversive to them, even or that's uncomfortable to them, even if it's at a low level, it can build up over time. So if there's a lot of noise in the environment, for example, and they're not necessarily feeling like they need to get themselves away from the noise in the moment, the low level of noise can be sitting in the background, activating their stress response over time, so that eventually they act out. And they were like, why are you acting out? Like there's nothing that's been changed the whole day. But really it's like the accumulation of that sensory discomfort or aversion can lead to behavioral reactions too. And so allowing a child to get out to scheduled or unscheduled breaks to get away from whatever sensory input it is that causes them stress can be very, very helpful. And then equally helpful is providing them access to counter sensory experiences. So allowing a child who needs to actively regulate, who's a sensory seeker, may be very helpful to help them regulate the other negative sensory input that they're getting. So allowing a kid access to fidgets, allowing them access to headphones, even if it's not all the time, but maybe frequent frequent opportunities through the day to engage in using those tools can help them regulate their overall sensory experience. And then stimming are the behavioral patterns that many children with neurodivergence engage in that help them to regulate their sensory experience. So, for example, rocking back and forth can be a use of the vestibular input, vestibular sense to help regulate other uncomfortable experiences. And so if we don't allow a child to rock or to flap or to pace back and forth, then we're not allowing them to use their ingrained natural ways of coping with their sensory um, experience and their own biological coping tools. And so stimming can be very, very helpful regulating behavior. And so we want to help children engage in this safely and in a way that doesn't distract them from other activities that we that they may be wanting to engage in. And other times when I've done sensory workshops like this, or when I've had families in clinic, many people are asking, how can I like help my child not do these behaviors anymore, to help them quote unquote seem more normal. And we're understanding that from learning from people who went through therapies in their youth to try to train out these coping skills, these stimming coping skills, that can be very, very disruptive and harmful to them as they grow older. And so we try very hard now to not train those behaviors away, but rather to train when it's okay to like help other people understand why they're doing it, so that you can engage sensory experience, engage in these stimming behaviors wherever you are. You don't have to hide it. But sometimes like pacing or rocking or other things can be distracting to the child or to other people around them. And so teaching other ways to get that input that's like more discreet, can be helpful. And so that's where occupational therapists and like experienced educators can be creative and helping kids learn another behavior that gets at that same need, but is more discreet. Or we allow a space for a child to like go to the back of the room or go to a different room if they need to engage in a more energetic behavior. Uh, but thinking about stimming in that way can sometimes be very helpful to parents, to grandparents, to teachers, to help understand that this is a part of neurologic difference and these are the underpinnings for it. And so I don't advocate stopping stimming or training it away. Some other recipes for support. I think I've covered most of these. At school, you can always ask for what's called a functional behavior analysis. And this is not specifically asking for ABA, but in Hawaii, with the way that our laws are written, many schools will think that if we ask for functional behavior analysis, that we are asking for ABA or applied behavior analysis. But actually what we want is whatever terminology your school uses, we want them to think about why a child is engaging in a behavior. And you want to think about this at home too and out in community. All behavior has some reason. And so thinking about the reason and thinking about potential sensory reasons can be really helpful for coming up with a plan. And occupational therapists tend to be the members of the health and educational teams that have the most experience with sensory processing. They're not always trained in this, and other people may have more experience. But if you request, you can always request an occupational therapist to help with this behavioral analysis and coming up with sensory regulation strategies. So, like those movement breaks, what we call sensory diet, or how they have access to activities to regulate. And then in the medical setting, I mentioned child life already. We can use those environmental modifications that we talked about earlier, and then using social stories or medical play or comfort positions and practicing can help children get used to and prepare for uncomfortable medical experiences. And social stories is like coming up with stories or reading stories about other people, reading or watching stories about other people who are visiting the dentist or visiting the doctor's office, or experiencing having a cast. Or you can create a story yourself, make up a story that features your child and help them understand what's happening to them. And as you read the story over and over again and you practice what your coping strategies are, what your child's coping strategies can be, what's available to them, it can help give more agency or ownership over reaction. Like, I know what's coming. I see the story that I'm familiar with playing out in real life, and I know the tools that I have. It gives them more ability to understand, react, and respond, which can be really helpful. Okay, and this is where we transition over to Susan, and Susan is doing her own presentation, and so I hope that you take the time to to listen to her and Roger, her son Roger, talk about their experience understanding Roger's sensory um, processing and how it impacted his early elementary all the way into his adulthood. Thank you very much for your time today. I hope that this presentation was helpful to you.